Welcome to Oncology Today, current and future role of CD19, CD3 bispecific T-cell engaging antibodies in the treatment of acute lymphoblastic leukemia. This is medical oncologist Dr. Neil Love. I met with Dr. Bijal Shah from the Moffitt Cancer Center in Tampa, Florida, to discuss the evolving role of novel CD19-directed therapies in managing ALL. To begin, I asked Dr. Shah to discuss the advent of blinatumomab in the therapeutic landscape of ALL and its current role.
So, blinatumomab is really the Cinderella story of acute lymphoblastic leukemia, or maybe oncology more broadly, right? We're talking about a molecule that was FDA approved in 2014 that is only in 2026 we're starting to see some potential contenders, including one Amgen, who makes blinatumomab, which is now a new way of delivering it. So how in the heck do we get here? We were really struggling with chemo-refractory leukemia. I mean, that's the bottom line. We're talking about 3 to 5% survivals. If you relapse with leukemia, particularly in your second relapse, the only ones we were really able to benefit were those younger patients whom we could take to a transplant as salvage if they hadn't already seen it. And so here we are now, circa 2010, we've got all these extraordinarily intense protocols, cytarabine-based, fludarabine, you name it. We're throwing all these drugs at folks, trying to build on lymphoma paradigms, building an asparaginase that we're building on from our pediatric leukemia paradigms, but we're just not advancing the curve. Folks are still relapsing and really with incurable disease, despite our best efforts. This is the space into which Blina came. And, it was initially tested in Europe, actually as a continuous infusion without break. Patients would wear this pump. You'd have to change out the pump every couple of days, and they just stayed on therapy indefinitely until the lymphoma or leukemia came back. And by the way, there's still long-term survivors from that trial that was initially done in lymphoma. But you wake up, you kind of realize this is not sustainable, and had to try to figure out how we're going to get this into patients. And I think initially in ALL, right, this is a disease with a huge unmet medical need, as I mentioned, and it was integrated for those who had relapsed and refractory disease. Again, some first salvage, some second salvage and beyond, but no limit, right, in terms of the number of therapies. And so patients could come on, receive this therapy, and wait a minute, it worked. I mean, I just got to pause there. It worked. We were seeing patients with where we never achieved a complete remission, we were seeing patients achieve these CRs. Now, we had challenges. We had challenges when it comes to tumor burden. Right now, the probability of seeing it work was way less. If they had extramedullary disease, we really weren't seeing it active in those places. Particularly, again, there were some barriers we couldn't surpass, and so we started asking the question: can we integrate the Blina earlier? Can we integrate it for lower disease burden? Can we do things to change this natural history so we're not on the back end in our second salvage trying to ask blinatumomab to do something that it's incapable of doing? And so it actually played out just like that. We started with an MRD-based study, so patients are getting their chemotherapy. We can now detect minimal residual disease, and we're asking about blinatumomab incorporation to see if it changes the natural history, and it did. We still need a transplant to really derive the maximum benefit out of that therapy. So again, we were changing the natural history, but now seeing cure rates hovering around 50%. This is not where we were. Traditionally, someone with minimal residual disease, especially after 3 intensive courses of chemotherapy, had something like a 10 or 20% survival. So we're shifting the curve. And, rightly, the next step was to say, well, okay, if this works that well for minimal residual disease, what happens if we just bring it up front, really pull it into our frontline therapies, independent of whether we see the disease or not? And that was the ECOG 1910 study, and it blew it out of the park. We could really show a tremendous benefit by incorporating blinatumomab. And I think to everyone, all of us who were doing it kind of realized this was going to be the case, but the really nice reassuring piece to this is we didn't just decrease relapse-related mortality, we decreased non-relapse-related mortality by simply giving adult patients, a break from multi-agent chemo. That was a really important observation. And now in 2026, you look at the NCCN guidelines, blinatumomab is recommended across the board for every patient who has CD19 positive BALL. We don't want anyone to be excluded from that. We are not, at this point in time, recommending that folks take chemo with the blina. We're not trying combinatorial approaches that way. We want to give people a break and give them the opportunity to benefit from the CD19-directed therapy. We're talking survivals now from this trial. We don't have the ITT comparison, but looking from the time of randomization of around 80-90%. So this is tremendous.
Before we go farther, just to take a breath, I was just kind of thinking, I remember when blinatumomab came out and the whole issue with the infusion and all, but, it was called a BiTE. And then when the bispecifics came into lymphoma, they called them bispecific antibodies. So first of all, I know that may be sort of a silly question, but are they the same terminology essentially? They look the same.
Similar, but not the same. Yeah, so when we talk about a BiTE, we're talking about trying to figure out how to take the FC portion, right? This is the part of the antibody that keeps it circulating. So why can we give rituximab once every 2 months and not have to repeat it? Because it's going to bind those FC gamma receptors in the spleen with that FC portion and really extend its half-life. There's a really cool experiment in mice, and I know I'm going off tangent here, but this cool experiment in mice where they said, what if we eliminate the cells that normally bind rituximab in this mouse model of lymphoma? And the answer is rituximab no longer works. And so it was really fascinating that the antibodies, traditional antibodies, needed that in order to maintain this half-life. When we talk about blinatumomab, that was stripped on purpose. We had no idea whether this molecule was going to be tolerated, right? We're activating T cells. We're grabbing T cells. We're grabbing leukemia cells. We're pulling them together, activating a T cell in the process. And look, if all craziness breaks out and those T cells go crazy and start producing a ton of cytokines, people are going to get really sick. Here now, if patients do experience toxicity, you hit pause on the infusion pump, and in 2.5 hours, half the antibody's gone.
I was kind of asking you to compare it to, what now is called bispecific antibodies often. For example, mosunetuzumab.
So where I was going with that is the blinatumomab is stripped of that FC portion. And so you've got the heavy chain, you've got the light chain, but instead of, having, being attached now to a traditional stalk, that's all you got. With bispecific antibodies, so not therapeutic engagers like blinatumomab, with the bispecific antibodies, now we're kind of keeping some of that antibody structure intact. We've got a stalk. But normally we think of our antibodies as having these two different binders that bind the same thing. Here we're saying, nope, one is going to bind our antigen of choice, in this case CD19 on the blasts. The other is going to bind CD3, in this case on T cells, to try and activate them. So what really distinguishes them is the rest of the structure of the molecule, having that FC gamma portion, that FC portion that's still present. And then when we talk about Mosun and Glofi and all of these other things, trying to figure out, does it make sense to keep it as it's normally constructed, or do we need to make changes, again, to try and minimize the toxicity, to minimize the amount of time that it's circulating?
So, for example, mosunetuzumab is a bispecific antibody, but blinatumomab is a BiTE?
That's correct.
And then, just out of curiosity, what was seen in lymphoma with blinatumomab?
It worked, but they had to push to high doses. And so now we're talking about pushing it. So typical dose with blinatumomab is going to be at 28 micrograms a day. We were having to push up to 112 micrograms to see that response, to get the blinatumomab into all of these non-bone marrow-based compartments. When we did that, we also ran into more toxicity, particularly neurologic toxicity. And it really kind of slowed the development down of blinatumomab in that space.
Really interesting. So let's talk about some of the new agents that are coming along, those CD19, CD3. Before you get into the comparison, particularly the two ones that you commented on, I think the most studied at this point, Suravatimab and the MK compound. Mm-hmm. What was the thinking in trying to develop these additional compounds? Yeah. Was it the idea that maybe they would be used sequentially or preferentially?
I think the ultimate goal is preferential. I mean, that's more of a pharma question than I can answer, but where we're starting from, right? Blina is now part of frontline therapy for all adults with ALL, with CD19 positive B-ALL. And so really we needed to show that we could still have some activity at all with these novel approaches. And that's really, really important. I think if we don't show that, then you're stuck, right? How do you take your drug through drug development if you're starting with a population that's likely going to be heavily exposed to Blina?
All right. And again, before you kind of get into new compounds, one other question I had. When you were talking about blinatumomab, one of the things I think I heard you say and describe was that there was a benefit in MRD negative patients?
Yes. And it makes you scratch your head, right? MRD is what we MRD is what we can detect. We're down to 10 to the minus 6, I think, with the adaptive platform. We're down to 10 to the minus 4 with flow cytometry. There's probably about 6 logs below that where we don't have technology that's going to get us to that level. And so, to answer your question, it's just a matter of what we can see. We do think that we're still acting on disease that exists well below that threshold.
And what do you see clinically in the MRD negative patients who don't get blinatumomab? What's the prognosis?
Well, luckily the prognosis is good, but it's not as good as what we would see in an MRD negative patient getting Blina. So to put that in perspective, we have to really get into the weeds a little bit when it comes to risk. So in high-risk patients, even when they achieve MRD negativity, we know that at least 30% of those patients are still likely to relapse over time. And I say at least because the longer you follow, the more likely you are to see something come up. And we also know that there's another category, so when I'm talking about risk in that way, I'm really talking about genomic risk. There's a whole separate category of risk that we just think about as a function of age. And here now, even when you achieve MRD negativity, the ability to be able to carry your patient through all of the subsequent cycles of chemotherapy safely without needing significant dose reductions, without there being other complications aligned to that therapy, coupled with other features that may be unique to those patients who are older, it's going to compromise your outcomes, right? So this is why when we talk about those patients 65 and older, we still consider those to be a fairly uniformly high-risk group of patients, independent of all the other features. And so here's a place where blinatumomab also has an opportunity, or I'll say immunotherapy has an opportunity to benefit because we're able to decrease intensity and come in with an effective agent.
One more question, maybe we can get into your cases, but also want to hear a little bit about these two new agents. So I'm fresh off of a webinar that sort of got my brain defibrillated with on cell mods with Paul Richardson and Natalie Callender a couple days ago. And one of the things that they were talking about, which I thought was really interesting and kind of flashed on when you were talking about it, was the effect of cell mods on extramedullary disease and myeloma. I know it's a completely different disease and syndrome, but we were getting into the whole issue of, why do you get extramedullary disease? What's the pathophysiology? What's the prognosis? Same question back to you in ALL. First of all, maybe talk a little bit more about sites of extramedullary disease. You mentioned that usually CNS disease is excluded, but I'd like to hear a little bit about CNS disease.
Sure.
And what's the challenge there? Is it anatomic, biologic? Why is it so difficult?
I don't think we understand all the dynamics of the tumor microenvironment in acute lymphoblastic leukemia outside of the bone marrow versus in the marrow. So I'll start there. We do know that it's going to be less permissive when we talk about immunotherapy and its ability to engage. And there's going to be certain very, very high-risk sites. And these are sites that we've seen in CAR T cell therapy as well. The pleura, the small bowel, in some cases the skin. We're just not going to be able to get because of immunoregulatory influences in those spaces. It's going to be a little bit more difficult, not impossible, but more difficult to see deep immune driven responses when we're depending on T cells to help carry out that effect. Now, you asked a question before you started, where does ALL pop up? And the answer is any place is fair game. The brain, the spinal cord, the bones, the liver, the lungs. We've seen it in bowel. We've seen it everywhere. And so in terms of why, that's a tough one. And I don't know that we understand the why. It doesn't seem like it's restricted to a specific genomic subgroup. It is enriched in patients who have P53, so it says there is something there, right? Something that makes the blast perhaps more unstable. But it's not like an AML where we can say, hey, the monocytic subtypes are more prone for, to grow outside the marrow. We don't have that kind of a phenotypic correlation. We do know for patients who have had extramedullary disease at any point in their disease course that they are more likely to have it in relapse or refractory disease settings. And so it is something that we have to be cognizant of, particularly as we start talking about some of these bispecific antibody-based approaches. Now, we are showing that these antibodies can work for extramedullary disease, particularly the surovatamig, where we have some early data now here. 9 of the 9 patients have responded. And it's going to be really important to track that and see how it goes. The last question you asked me was about central nervous system disease. And I think this is one that many of us in the ALL sort of community really want some clarity, some insight into. These patients are often excluded from clinical trials. And so, with the concern being that maybe they're more prone to develop neurologic side effects, and we don't want to attribute that to our drug, and so we want to be extra careful. But what it's created is another group of unmet medical need. And so we don't have a good sense. Do the antibodies cross? I mean, really cool data that came out of I think Elizabeth Buddy published the trial with glofitamab, this bispecific antibody in lymphoma, actually being active in patients who had central nervous system disease. You wouldn't have predicted that. I wouldn't have predicted that. We see this profound CSF pleocytosis, right? All these lymphocytes in the CSF when patients are receiving these bispecific antibodies. Is that with the antibodies still bound to their cell surface, or what are they doing there? And what does that mean in terms of whether the antibody's crossing or whether the cells are crossing with antibody bound to them? Are they going to be able to fight cancer in those spaces? We do know that conventional IV blina doesn't work. We know that. We're going to learn whether sub-Q, whether that enhanced PK that we get with sub-Q blinatumomab or surovatamig or the MK compound will get us into those places. And we're going to learn because what's nice, at least I can say this for the surovatamig trial, we're still allowed to do, and for the sub-Q blin, for both of those studies, we're allowed to do lumbar punctures, meaning we're allowed to prophylax. And so I think we're going to be able to collect the CSF, we're going to learn from it, and if it's crossing, man, that's going to be really cool.
So let's talk a little bit about at least these two new agents. Let's start out with surovatamig, and you talk a little bit about sort of how it's constructed, how it compares to blinatumomab, and particularly what we've seen in clinical trials.
So surovatamig is now a true bispecific antibody. It's a truly human antibody, so it's not humanized. It was made with this unique, platform that incorporates human genes for making these antibodies. It's got a couple of features that make it really well poised for the treatment of ALL and lymphoma, by the way. This molecule is also being studied in follicular and large cell and mantle cell and everywhere. But it's first got this FC portion, that stalk, it's silenced, meaning it's less able to bind FC gamma receptors. And so we don't have to worry about this prolonged toxicity. So if someone develops CRS or ICANS, which, by the way, is really rare with this particular molecule, you give some steroids, it goes away, the molecule's gone, and you're fine. The half-life is somewhere around 10, 12 hours. It's also got a low affinity CD3 binder. And this is important because it's binding the T cells in a more physiologic manner. And when it does so, we're less likely to see cytokine production, like high production of interleukin 6, for example. And this can also help to really reduce the probability of high-grade CRS or again, the neurologic side effects that we see with immunotherapy. And then finally, it's got this very unique CD19 binder. And this is the one I'm not going to be able to speak to because I don't actually know yet how that's going to differentiate the molecule, but it lacks the light chain completely. It's just a heavy chain binder. And whether that's going to somehow enable the antibody to bind closer, to the cell surface, whether it's going to have some other impact in terms of the interaction between T cells and B cells, I have no idea. But it is very, very cool to think about the construction of this antibody. In terms of the clinical trial data, very promising so far. What we're seeing amongst the patients who were treated, around 70 to 80% overall response rates across different segments of risk. And I'll break that down for you a little bit. We looked at patients who had seen prior blinatumomab, prior CAR T cell therapy, what we call double exposed, those patients who had seen both, and patients who had seen blinatumomab, CAR T cell therapy, and inotuzumab, a CD22 antibody drug conjugate. And what we saw was the responses were preserved, again, around 80-ish, 70, 80, call it right around 80% to keep it simple, complete remissions with this drug. What's also very encouraging is these are deep remissions. About 60% of these patients are achieving MRD at 10 to the minus 6, so the deepest remission that we can identify. They're achieving it early, meaning as soon as the first cycle, and the safety seems to be preserved. Now, we did have to test how to properly escalate the dose to make sure that we weren't pushing people to too high a dose too quickly. When we do that, we're more likely to see cytokine release syndrome or these neurologic side effects. Again, I always like to think of it very simply. Tumor burden drives toxicity. So, if you push too high a dose too soon, you're going to run into problems. When we use the low step-up dosing, we saw really no high-grade CRS or ICANS. It really proved to be a very, very safe and well-tolerated ramp-up. When we move to the therapeutic dosing, again, very, very rare cases of CRS and ICANS, it really seems to preserve this benefit. So we'll see where we land as we accrue more patients. We're still testing higher doses. So there's still we've got data up to 15 milligrams. We're going to test 25. We're going to test 37.5. We're going to try to learn from this molecule as much as we can. But the reason we're going to do that, Neil, is we haven't seen any significant dose-limiting toxicities to date to tell us, hey, we need to stop. I mean, this really seems to be pretty safe.
Can you just maybe go through also the MK compound, again, why it's different than the other two and what we know about it? MK1045, which again this was studied in China under the acronym CN201. This is also a bispecific antibody in the sense that it contains this Fc stock, and it is also silenced to limit its half-life, again somewhere around 8 to 12 hours. Also with a low affinity binder to CD3 to minimize some of the cytokine production that may occur as a consequence, but with now a more conventional binder to CD19. So this looks just almost like an antibody, except it has one stock binds 19 and one stock binds CD3. So a little more traditional in its shape. And this was studied in a phase 1 dose escalation study and really showed, again, extraordinarily low rates of CRS and ICANS. The grade 3 plus ICANS rate with this molecule, 0. None were seen. When we talk about, grade 3 rates of CRS, also extraordinarily low, 2%. Again, across 75 patients, they were seeing tremendous tolerability. In terms of activity, we're still learning. At the 60 and 90 milligram doses, the two highest doses tested look to be very, very active. Around 80%, if I recall, was the response rate.
What we don't know is whether it's going to work in our Blina and CAR T exposed patients. Because this was done ex-US, I think we're still trying to understand as we go forward, as we move from to really doing these relapse refractory studies in the United States, is it going to have that that same tolerance, that same activity? We also want to make sure that it's going to work in patients with very high blast burden. The blast burden is a little bit lower on the study compared to Survodimig, and so we just want to make sure it's going to work. But all the reason in the world to be excited about it, especially, and again, it's a brave new world, right, Neil? Especially if this works after Survodimig. I mean, you can imagine now we're talking about recycling our CD19-directed approaches and trying to make sure we still have a shot on goal. So I think a lot to be learned as we go forward.
So again, maybe you can just sort of capsulize some of the ongoing trials you're most excited about looking at all three of these agents.
Yeah. I'm very excited about what we're doing with sub-Q Blin. So although, and again, I didn't mention this earlier, sub-Q Blin does come with more cytokine release and ICANS. There's no question. We're seeing about 15 to 20% grade 3 CRS and ICANS with the sub-Q Blin. But here's the caveat. It was given to people with high burden relapse refractory disease. And the way that it's dosed, again, there wasn't as much of a ramp up. They really came in at a, 250 microgram dose sub-Q and, just counted on the absorption kinetics to really drive what happened next. They were hitting PKs that were considerably higher than what we get with CIV, continuous IV Blin. And so perhaps expectedly some toxicity. So what am I excited about? Moving into the frontline setting in MRD patients. So now you get a couple cycles of chemotherapy, you bring in your sub-Q Blin in low disease burden settings, you're unlikely to see much of any toxicity, but you have that enhanced PK that's really going to push it over the top. That's really going to say, hey, is this a replacement for conventional IV Blina? And by the way, you're delivering it sub-Q, no more being attached to a pump for a month at a time. So this is going to be a non-inferiority study set against IV Blina. We're going to learn what comes of that. With the Survodimig, we're still in phase 1. So I think we still have some dose escalation testing to be done. If you ask me where do I think we're going, I would imagine the next place is going to be what are the unmet needs that we still want to make sure we address. I highlighted the fact that older patients are still a group of patients where we need to improve outcomes. So can we've seen trials of blinatumab and inotuzumab in combination for that group just as standalone chemo-free therapy. Is this a place where we need to bring Survodimig in the newly diagnosed setting? We now have Blina and TKI, so for our Philly positive patients, completely chemo-free. Another place where I see a tremendous opportunity to perhaps build on some of those response rates because, the blinaponatinib, as amazing as it is, the main reason patients failed was CNS progression. So if we have a more potent molecule that's going to really get us into some of those tight spaces, we may be talking about really kind of changing that paradigm for how we deliver it. What about MK? Oh my goodness, we haven't even started in the U.S. It's going to be harder for me to, talk about where we are with MK, but I will say for all of these molecules, there's one big elephant in the room that we haven't talked about, and that's CAR T. And how is CAR T going to pivot? Yeah, I mean, also extraordinary responses, time-limited therapy, right? You just give it and then you watch. Or maybe punctuated therapy is a better way to think about it. How is that going to be integrated in the front line? And what does that mean for these antibodies? Are they part of that paradigm? Are we delivering it before and after, like we're seeing some clinical trials now start to do with glofitamab and CAR T or Mosunpola and CAR T? Or is this going to be, first salvage is going to be where we stick to our antibodies? CAR T is now our treatment of choice. And why would I say it in that particular way? Because we're starting to see data come out of MD Anderson. Ibrahim Aldos out of City of Hope did a trial just in 55 and older with CAR T-cell therapy after an induction. These patients are showing sustained, durable remissions with this 19-directed therapy. And so there's still, again, 20, 30% where we got to be aware that there's something that can go wrong. But it tells us that this is a viable approach for our older patients. And you know what happens next? Once it works, we go further back. We start testing it in younger patients. And I should say, in that same breath, we have a frontline study that we're doing right now that we're limiting to MRD positive patients who are positive post-induction getting CAR T. We give them the opportunity to receive CAR T-cell immunotherapy in that setting.
Which CAR T products are being used and studied?
Brexucel is the first, well, I should say Tisagen Laclusil was the first to be approved. This was approved up to the age of 25 and was the first to really see some activity in adults. But the first truly adult CAR T-cell trial was the brexucabtagene autoleucel trial, also goes by the name Tecartus. Brexucel was studied in around 78 patients or so at the recommended dose. And again, very high response rates, 50% survival at 5 years. This was in a predominantly salvage 2+ setting, so very heavily pretreated patients, very high tumor burden, very active, but did come with some CRS and ICANS. And so I think it led Autolus, who makes a competing CAR T called obacabtagene autoleucel, to really say, well, what if we tweak this a little bit and changing the structure a little bit of that CAR. They did indeed, and by the way, the delivery as well, they did indeed see lower rates of cytokine release, lower rates of neurologic toxicities. And while I'll say that none of this is likely to inform mortality, right? It's very rare to see someone pass away from these toxicities. Hospital systems, well, they don't. It's the strangest thing in the world. They don't want them in the hospital. We got to find ways to keep people out of the hospital to get reimbursed. We got to find ways to keep people out of the hospital to, again, improve the metrics for the hospital. And I think this is what we're seeing with obacabtagene autoleucel. It really is starting to, really step into the forefront now for CAR T-cell therapy in ALL. I still am a big Brexucel believer. I led that trial, and so I still love it. But I have to say that, there are financial dynamics here that we have to keep in the back of our mind.
Interesting. All right, let's get into your cases. Let's hear about your 59-year-old lady.
Yeah, this was a 59-year-old I saw way back in 2022. She came in with newly diagnosed ALL, kind of a tough situation, to put it bluntly. She has multiple sclerosis with spastic quadriplegia and completely bedbound. So when we talk about ECOG, or ECOG is 4. She had a preserved hemoglobin around 12, although I'll tell you, once we started, before we even started therapy, she dropped to 10. So, she was starting to drop her counts pretty quick. Platelets preserved around 222, neutrophils preserved, but the blasts were around 14,000. So, she was starting to take off. Got a marrow, 80% cellularity, essentially replaced by BALL. Cytogenetics showed us the Philadelphia chromosome, the classic 922 translocation. FISH and PCR confirmed it. We also saw this deletion 7, and it's one of these where I scratch my head when you start seeing some of these myeloid type mutations. You always get a little bit more worried in that setting. We did get next generation sequencing. I'll be honest, that was reduced sensitivity. I think for whatever reason, didn't get a great sample for the NGS, but we saw the Philadelphia chromosome, and we also saw some variants in some interesting genes like CUX1 and XBP1. Imaging-wise, not a ton in the way of extramedullary disease. She might have had some liver and spleen involvement. We saw very modest splenomegaly, about 14 centimeters, very modest hepatomegaly at 25 centimeters. But the steatosis was probably driving both of those. Some left adrenal nodularity, which hard to say what that was. But, when I talk about the comorbidities, that was the real challenge here. And it wasn't just the bedbound status, spastic quadriplegia. She already has a history now of DVT and PE. She's got a filter. She's coming to us on anticoagulation, diabetes, an ileostomy, an intrathecal baclofen pump. So now we're talking about what are we going to do to deliver this woman's intrathecal prophylaxis, vesicovaginal fistula, and chronic carriage of a resistant E. coli. So, this was a tough case, and so we had to really think hard about. First step, what are we going to do to start? How are we going to how are we going to get this woman immunotherapy? I mean, you could say, Dr. Shah, why don't you start right now, put her on blinatumomab. Look, with blast that high, she's going to progress pretty rapidly, right? And so what we chose to do was to give a very low intensity induction. Here we chose mini CVD. I felt comfortable with ponatinib in this setting because she was already on anticoagulation for a DVT and PE. But it is important to recognize the vascular toxicity of ponatinib. It is not, at high doses, it is one that you really got to take very, very seriously. And then we had to place an Ommaya for the delivery of her intrathecal chemotherapy because she's got the pump on her back. Now, why did I feel comfortable with mini CVD? Why did I feel comfortable backing down from, typical hyper CVAD or maybe one of the other European inductions? And really, it's the Graf 2005 regimen that kind of gave me that ammunition. And I put a figure here on the slides for those that are watching the video. We saw similar complete remissions, similar major molecular responses, similar complete molecular responses, and a lower rate of death when we backed away from the intensity of hyper CVAD. And what was that? In the Graf 2005, it was 4 weekly doses of zinc, steroids, and actually with an imatinib backbone. So, we're seeing upwards of 40% major molecular responses with an imatinib backbone on, with Vinc and Dex. It was really hard for me to push for, intensive chemotherapy with that data set. And actually, most of our patients now are not receiving high-dose chemotherapy now as their induction, unless they're coming in with known extramedullary disease or lymphoblastic or something unusual. This woman, we started her on this mini CVD. She did have a UTI, perhaps as expected with all that she had going on, but she was able to clear it. COVID-19, which is always scary when you have someone with a lot of comorbidities, but again, we were able to get her through it. And she achieved a complete remission with MRD positivity. She had a 3 log reduction in her BCR-ABL, so fitting that criteria for major molecular response, and about a 2 log decline in her clonoSEQ. And so really, she did very, very well and gave us that ammunition we needed now to move into blinatumomab as consolidation. So we've reduced our disease burden. We feel comfortable now bringing in the blina. We give it together with ponatinib. We drop the dose of ponatinib. And again, we always have to maintain intrathecal prophylaxis. I mentioned it earlier in our conversation, but central nervous system progression is one of the things you got to be aware of when you're giving blinatumomab, as well as other extramedullary sites. So we delivered this cycle entirely as an outpatient. Again, she's bedbound. Again, one of the challenges we run into is rehab is not going to be able to deliver her back and forth for bag changes every 2 days or even every 7 days. And so we were really restricted in terms of what we could do. So we delivered the blin as an inpatient and gave it together with ponatinib at 30 milligrams and our intra-Ommaya prophylaxis. She had a really benign course. She had a fever on day 1. That was it. She completed the entire course, no major toxicities. And by the end of the cycle is in a complete molecular remission. Nothing detectable by clonoSEQ, nothing detectable by BCR-ABL. And so we do what we always say, right? The trial said you're supposed to give 5 cycles of blinatumomab, and so we're going to give you 5 cycles of blinatumomab. And she says, oh, wait, Dr. Shah. No, I can't come back. This is it. What do you mean? And we don't have data for 1 cycle of blina and ponatinib. I mean, we're really pushing our luck here. And she said, nope, this is the best I can do. With all the restrictions I have, being bedbound, being everything, this is what I can do. We moved her to ponatinib, monotherapy. We kept her on the higher dose for about 6 months before dropping her to the low dose. I can tell you that she remains in an ongoing complete molecular remission. She's now well over 3 years since starting the blina and ponatinib combination. And I think it really speaks to the promise of what we're trying to do with immunotherapy, and that's really why I wanted to talk about this case. It's certainly, if anyone had looked at the same patient 5 years ago or even 10 years ago, it would have been a hospice discussion, unquestionably. She's now, again, in a sustained remission and continues to do very, very well. I think one of the questions I don't know is whether it will ever be safe to stop her TKI. We have stopped the ponatinib in a handful of patients who have sustained molecular remissions going beyond 2 years. For her, with the shortened blina course, she'll probably be on ponatinib for a little while, at least until we see some toxicity from the ponatinib that tells us we have to stop. But one of these, when I talk about the promise of immunotherapy, this is why I get so excited.
So it is an incredible case. I just have to ask you one other question before you get to your next case, which is, could you talk a little bit more about her as a person and what it was like to take care of her? I mean, I'm trying to get a mental image of this, and it's just like amazing to even think about it.
First of all, she had considerable spunk. I mean, I have to tell you, she's a sweetheart, by the way. I mean, she really, there are some people who come in and, I don't know how else to put it, they've sort of decided, okay, I don't want therapy. I'm ready to take hospice. No, she came in, she said, Dr. Shah, I'm here because I want you to get me better. And, although she had the spastic quadriplegia, right, she's really struggling now to kind of do some of the things that we consider more simple, feeding and so on. But she's functional, and she's telling us outright, like, I'm here in the hopes that you can offer me some hope of getting past this. And I mean, when I talk about someone who's involved in her care, I mean, she was there. I mean, every single day she's there. She wants to get better. She's going to do what it takes to get better. And I'm not going to say it wasn't, there weren't challenging moments like when she had COVID-19, but she really did amazing. And it's kind of that testament to her desire to, I'm going to beat this.
I'm sort of flashing on the fact that we were just at the San Antonio breast cancer meeting in December presenting cases. One was a 103-year-old woman.
I love it. I love it.
They were like, she wanted to be treated. She was just like this lady. We had incredible, basic response. Age 103. All right. 50-year-old woman.
This is a tougher case. And I wanted to talk about the limitations of immunotherapy. And this is a case where I'm going to try and dig a little into that. So this is a 50-year-old woman who presented with back pain and pancytopenia. And the first thing you have to think when you see pancytopenia in someone who's ultimately diagnosed with ALL is, there's something bad under the hood. Leukemia should be proliferative. We should see a high white cell count, 20s, 30s. But if you come in and you're pancytopenic, in this case, white count of around 2, hemoglobin 8, platelets 50s, ANC essentially 0, you got to be worried. And sure enough, marrow's 95% cellular, greater than 80% blast, and the karyotype, hypodiploid, is the predominant clone. It's about 4 of the 7 metaphases. The other, hyperhaplodiploid, right? So a cell that underwent division but didn't actually form 2 cells. So, we've got this hypodiploid or hyperhaplodiploid karyotype, and we know what's under the hood there, even though we don't have NGS. That's TP53. It's screaming TP53. And sure enough, we didn't have it at diagnosis, but in follow-up, we confirmed that she truly is, in fact, a TP53 mutated BALL. Well, couple the chemo insensitivity that we know comes with TP53 mutations, she's also got a lot of disease outside of her marrow. Multiple enhancing spinal lesions. She's got extradural extension, nodular lesions in her pancreas, her kidney, and her right adrenal gland. And I remember you were asking, hey, where can ALL go? And the answer is everywhere. And that's what she was doing. She was 50, right? And we kind of think of 50 as being the upper limit for standard, pediatric-inspired therapy. And that's what she got. She got the induction consolidation using the CalGB 10403 regimen. Dropped the pegosparaginase dose a little bit, but not a lot. And lots of good data to show that's an effective dose. She did okay. She definitely experienced some pegosparaginase toxicity, grade 2 pancreatitis, elevated triglycerides, bilateral upper extremity blood clots, some neuropathy from all the extra vincristine, and post-induction still MRD positive. 3.3% blast by flow. Again, some improvement in the T8 soft tissue mass, but I wouldn't call it dramatic. She does go on to consolidation and gets to an MRD negative response. I'll tell you that she very likely still had disease by clonoSEQ, but that's a tougher one to say because she wasn't treated for these initial 2 cycles at our center. I put this figure on the right for those that are watching the video, and it's just asking a simple question. If you're MRD positive with modern regimens that include blinatumomab or inotuzumab, venetoclax, whatever it is, if you're MRD positive after your induction, but you subsequently clear, what does your outcome look like? Do you have does that suddenly change the dynamic, right? Because we're integrating some of these novel agents to help eradicate that MRD. Is that going to make things, lightning better, considerably better? And the answer was no. 58% of the patients converted to MRD negativity. And I will say that those who did a little bit better, but there was no significant difference between those that maintained MRD positivity and those that did not. The p-value is about 0.23. Small numbers, won't argue there. But really the group that did best were those that achieved early MRD negativity, meaning post-induction. And that's why we actually changed our practice. We were using a post-consolidation time point, just like as you saw here, to really guide our decision-making. But seeing this data and others now, particularly these more sensitive clonoSEQ assays, has really pushed us to think about post-induction MRD. So she goes on to receive blinatumomab. Again, this was started before she had arrived at our center. But coming to see us, we're seeing her after her second cycle. We don't see any MRD by clonoSEQ, and so we're reassured. We're saying, okay, well, maybe you're not one of the bad ones. We see this weird hematogone hyperplasia pattern. I'll talk about that in a little bit, but that is a strange thing to see in a marrow that's after 2 cycles of blinatumomab. By the time we get her through her 4th cycle, she's demonstrating overt progression. She's got 10% lymphoblasts in her marrow. She's got, by PET imaging, extramedullary progression in her left hip and femur, and this is biopsy proven. And one of the hard parts here is the CD19 expression is now dim, weak if we're talking about immunohistochemical expression. And I put this figure on the right. This is, again, another paper from Ibrahim Aldas. I feel bad that I keep pulling his papers. Lots of good data out there on P53, but this one I think had a really nice graphic accompanying it, showing what happened in those patients who received blinatumomab, the majority, by the way, in CR. And for those that received it, you can see the outcome was far worse, essentially 0%, still in remission, alive beyond 2 years. You can see here that the majority of them were progressing with CD19 negative disease. Very similar to what we observed in our case, and speaking to how genomic risk can underlie what we see when it comes to immunotherapy. And so what did we do next? Well, she still has some CD19, so I tried to take her to Brexucel. I talked about how toxicity differs. Brexucel has the ability to engage and kill cancer cells with lower CD19 expression relative to what we call 4-1BB signaling CAR-Ts like Ovacel. And so I was hopeful I would see something, but I didn't. She still had residual disease at day 28. We put her on venetoclax-based therapy, and this is where we finally saw some benefit. She got about a year out of ven-based therapy before showing marrow progression, now greater than 80% blasts. We tried to give her pegosparaginase again. She didn't tolerate it. We gave her a Rylase, which is better tolerated, but we couldn't get on top of her disease. Inotuzumab, same thing, progressed. High-dose chemo, because we really hadn't given her a lot of chemo over the years, but again, consistent with P53, no response. Finally, palliation with mercaptopurine and steroids, and she passed away. But, although I talk about this as a, kind of one of our challenges with Blinn and kind of a difficult sort of journey, I want to point out some of the really cool things here. One, she made it 50 months from diagnosis with a hypodiploid karyotype. I didn't mention she also had a transplant in between, which also didn't work. She survived 50 months. Almost, actually over 4 years. She got to see her daughter get married. Almost made it to the birth of her first grandbaby. I mean, this is not something that we were achieving. And although this is really, we're focusing on immunotherapy here and some of the challenges, just want to reiterate that we are making progress in a lot of spaces, and you got to wonder if we could have found a way to somehow incorporate the ven with the blin or done something a little bit differently, whether we could have extended her survival. It's hard to say, but I want to make sure I don't end this, although difficult case, on a negative note, because there were a lot of really incredible things that she was able to do as a consequence of the therapies that she received. And, really the secret sauce was just not pushing too hard. I mean, again, not that I didn't try hard with chemo, but not pushing too hard with chemo, keeping her in good shape and getting her through. And again, one of the promises of immunotherapy. Could I have done better with Surivatamig or MK or subcublin? This is a great question. Right? If we're seeing CD19 loss, it means that one of two things. Either it's biologically baked in, it's possible, or, the therapeutic pressure is insufficient to kill them. And so we preserve this population with CD19 dim expression that now is better able to evade immunotherapy. And one of the things that we're trying to learn with these newer compounds is whether they're going to allow us to overcome some of these barriers that I'm describing by virtue of hitting those higher PKs, getting better exposure, getting deeper basically into the sort of these ALL pockets to clear out disease. And if that happens, then we may be talking about the next P53 patient I see showing durable, meaningful survival without relapse.
So incredibly instructive case. I don't know if I'm too fixated on names, but just to clarify, is there a difference between Brexucel and Axucel?
There is. So Brexucel or brexacaptine autoleucel is going to isolate the T cells before they go into manufacture. So one of the concerns in mantle cell and ALL was what happens if these patients come with a very high circulating blast count. And if we take all of that and go into manufacturing, a couple of things can go wrong. One is the blast could somehow impede the growth of the T cells during manufacture. We may not collect enough of the T cells. But the other bigger concern that I have is if you overactivate T cells before you put them back in, then they're not going to have the same journey once you reinfuse them, right? They're already going to be kind of quasi-exhausted before you reinfuse them. And so the goal with isolating them first before infusing was to preserve the health of the T cells. And it certainly seemed to help. I mean, we were getting by with absolute lymphocyte counts as low as 100 to 200 for the ZUMA-3 trial and able to successfully manufacture product. Axucel, on the other hand, doesn't do that. Axucel is just whatever we collect, whatever T cells and whatever's with the T cells, the monocytes, whatever the mononuclear cells are there, we're collecting and taking to manufacturing. And so that is one of the key differences between the two.
Not to get too far off, but what about in CLL? I know, there are lysocells used, but again, same basic idea?
Lysocell, it is the same basic idea. The distinction is lysocell is going to now separately isolate CD4s and CD8s. Their goal was to try to preserve the ratio of CD4s to CD8s to see whether that would further improve the toxicity and potentially even extend to the benefit. I mean, there's emerging data now that says that or suggests that CD4 positive T cells may be driving more of the toxicity, at least comparable to the CD8 cells. And so there may be some truth to that. I think that, but that was the goal. Now, it wasn't the only change that they made, right? They also used a 4-1BB signaling domain to further try to decrease on that toxicity rate.
All right, let's finish out with your 52-year-old man.
Yes. So this, again, similar age patient, 52 years old. He's coming to us. He's got a history of psoriasis, but really nothing else. He gets a pneumonia, again, it's not what I would call consolidation pneumonia. It's one of these like ground glass kind of change pneumonias and some sinusitis. But in the course of that, his counts really start to take a nosedive. Hemoglobin 7, platelets 11, ANC 0.3, and we're now seeing blasts in circulation. Blasts now around 17,000. And this elevated LDH, almost 5 times the upper limit of normal. I mean, this guy's got something really ugly going on in his marrow. And sure enough, that's exactly what we found. 100% cellularity, effectively replaced by 19 positive blasts. And with a kind of unusual phenotype, and, I don't like to dig too deep into phenotypes when we talk about the ALL, but it does give us some hints, right? So CD10 was not uniformly expressed. When we talk about pre-B cell ALL, it really should be. you're already scratching your head and saying something's weird. CD2, I'll come back to that on the next slide. I know we all think of CD2 as a T cell marker, but it does give us some insight. And the same thing, CD58. These are telling us a story about what his leukemia is like and what it's likely to do. And so these are sort of observations that I think inform how we think about the genetics and his therapy. And so cytogenetics, we see this dicentric 920 translocation. And when you see that, it's really, in ALL, it's very typical of a PAX5 rearrangement with ASXL1. And so we did do the next generation sequencing. We didn't pick up on it by RNA-seq, but knowing that genomically was present makes me think it was very likely a driver of his leukemia. And why am I saying that? And again, as I'll show you on the next slide, CD2 is usually present in PAX5 that only carries that P80R mutation. If you're seeing some other abnormality of PAX5, you tend to lose that. And again, it just sort of enriches this probability. That's what we're talking about here. Now, it's got a host of other things: CDKN2A2B loss, KRAS mutation, NRAS mutation, PTPN signaling. So really a proliferative drive for this gentleman's ALL, with this abnormality in B-cell development coming from this broken PAX5. Imaging, thankfully, doesn't show us much, some mild splenomegaly, but that's about it. And so this is the slide where I kind of show what we're seeing in terms of different genotypes in ALL. And it's important. It's important because if you go back just a few years, there was pH positive, there was pH negative, and that was it. In 2026, we no longer have that. We can't be comfortable with that anymore. We've now got some 20 some odd types of B-cell ALL, and we're now really trying to go a step further and distinguish intermediate, high, and standard risk B ALLs to help characterize our expectations. And when we talk about PAX5 alt, again, not just the P80R, or not but having other abnormalities, this is an intermediate risk subgroup when we talk about 5-year survival. And again, on the figure, you can see the 5-year survival is hovering around 30%. Sorry. And so what did we see in his treatment specifically? Post-induction, we've still got MRD positivity. It's 1 times 10 to the minus 5. I told you before, I was trying to give folks another cycle, particularly knowing that this P80R. I said, well, maybe, I'm not sure what the driver is. Let's give you another cycle and see if we can deepen it. But we saw the exact opposite. After the second cycle of hyper-CVAD, his MRD went up. So it increased by a log, and so the cat's out of the bag here. This is high-risk B-ALL. And, before I talk about what we did next, I've got this really, really complicated figure, Neil, on the right, which is designed to show only one thing. This is, again, data by Jun Yang, but when PAX5 is abnormal, we often lose expression of CD58, just like we saw in this case. And you're saying, well, what difference does it make? CD58, it's one of these flow markers. Who cares? I mean, it just helps you pick up on MRD. Actually, it really does matter in the context of immunotherapy. When T cells bind to cancer cells using bispecific antibodies, even CAR T, they're binding not just through the antibody, but through the interaction of CD58 and what's called LFA2 on the T cell. And absent that binding, yes, they can still attach, but it's a looser attachment. And so the ability to effectively secrete perforin, secrete granzyme, and kill the cancer cell is going to be reduced in that setting. And so this work, again, that I have here on the right is all designed to highlight that challenge and to help folks understand why the next step in this case for us wasn't to pivot directly to Blina, as you've seen me do in the other cases, but actually to inotuzumab. So we said, you know what, you don't have extramedullary disease, but you still have marrow disease. Let's see if we can clear it with inotuzumab. We give it together again with the same hyper-CVAD backbone without the anthracycline, reducing the dose of some of the chemotherapy, what we call mini CVD. And again, overall well tolerated. He starts to develop some neuropathy, actually grade 2 from all the vincristine exposure. Febrile neutropenia, common to see cytopenias with inotuzumab, but again, gets through it, no problem. But on the back end, no change. So we go 3 cycles of the mini CVD inotuzumab. He's still got MRD at 1 × 10⁻⁴. And so I say, you know what? I know the CD58's broken, but, if I'm going to dig into a CD19-directed therapy at this point, let's go directly to CAR T-cell immunotherapy. And so I take him to Brexucel, and he gets a deep remission. Okay, well, I'm excited. Counts are recovering. He looks good. He feels good. We see this weird thing in his marrow, and I told you I was going to come back to this hematogone hyperplasia on almost every single marrow, but with no circulating B cells. And so I joke around with my colleagues, I've created this new term. This is not in the WHO, people, so anyone who goes home, do not say this to your hematopathologist unless you want to get in a lot of trouble. But I created this term called lymphodysplasia. His marrow is trying to produce B cells. It's failing. They're never making it into circulation. But every time we look, we see this consistent hematogone overproduction, these early B cells that the marrow's trying to make, and never succeeds. Lo and behold, 18 months later, on this background, he relapses. We've got a 70% cellular marrow, 90% blasts. But then we see something else really weird that gets back to this idea of lymphodysplasia. It's a new cytogenetic pattern. It's not the translocation he had before. We've got 2 discrete abnormalities on chromosome 9. By clonoSEQ, there are 2 entirely new clones that have come up with this disease. And by flow, what we see is also distinct, a truly CD19, 10, and 58 positive population. Weird. But I'm going to tell you, when you really start digging into late relapses with CAR T-cell therapy, we're probably going to see more and more of that. We take him to the Survivotamig trial, and this is one of the ones that we've talked about today. This is a gentleman who's now seen inotuzumab without response, saw CAR T with subsequent relapse or new disease, however you want to think about it. We take him to a potent CD19 bispecific antibody. He gets a little bit of fever with his first dose, nothing else. He has transient neutropenia during his treatment course, a little rash around his port site. Weren't sure if it was cellulitis. It was probably, honestly, something related to psoriasis. He achieves MRD positivity, but at 1 × 10⁻⁵ at cycle 1. We continue him through cycle 2. He achieves MRD negativity at 10⁻⁶, and he has maintained that. He's been on trial for over 6 months. And the graphic on the right is the graphic I showed during my initial presentation, just highlighting the time points for toxicity. Again, that very first dose is when we're going to see a little bit of fever. We don't tend to see much else. And he's had no other major side effects throughout his entire treatment course. He's really done phenomenal, and I think a testament to what we can achieve as we start bringing our novel antibodies forward.
This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. The use of agents and treatments that are not approved may be discussed, so check out the package insert for more. Special thanks to Dr. Shah, and thank you for listening. This is Dr. Neil Love for Oncology Today.